Good evening, everyone. Thank you for joining Shield Connect. And I also thanks to all the participants, viewers, doctors, and coordinators to make this webinar possible on Shield Connect. So today, the exchange webinar is presented by SAFOG and IN Donald School International Academic Exchange Webinar. And the webinar is on the topic Imaging the Fetus. So let me introduce our coordinators of the webinar, Dr. Sonal Panchal, Dr. Monisha Singh, and Dr. Ankita Goyal. So first, let me give introduction of Dr. Sonal Panchal. Ma'am is currently consultant of Dr. Nagoris Institute for Infertility and IVF in Ahmedabad, India. Ma'am is also National Academic Director of Iron Donald School, India, and a director of Center of Excellence in Iron Donald Inter-University School of Medical Ultrasound in Ahmedabad, India. Ma'am is a reviewer for Journal of Human Reproductive Science. Ma'am is also a National Advisory Board member for International Journal of Infertility and Fetal Medicines of JP publication. Ma'am has published 35 papers in national and international conferences and journals. Ma'am has delivered more than 800 lectures and contributed in and authored several books, more than 120 chapters. So now let me also introduce Dr. Monisha Singh. Ma'am is currently consultant at Parul Hospital, Varanasi. Ma'am is recently winner of Foxy ISAP YTP MTP Award in 2021. Ma'am is also winner of IMA for Dr. D.S. Munagekar Award for Research in 2021, and ma'am also won many national and international papers and posters, and has published her thesis in Q2 journal in IJMR 2020. And ma'am is also active member of Young Talent Promotion Committee of 2020 to 2023. And ma'am is also active on social media platform uplifting the sexual health of the society at Dr. Wonder Woman. And also ma'am is the chairperson in Promote Positive Health in Rotary Club of Varanasi North for year 21 to 22, and member of Robin Hood Army. And I also welcome Dr. Ankita Goyal. Ma'am has done fellowship in colposcopy at Sainivas Healthcare in Mumbai, and ma'am is consultant in Department of Obstetric and Gynecology at Sankalpa Hospital in Ambikapur, and has gained expertise in field of laparoscopic surgery, especially total laparoscopic hysterectomy. So I welcome you all the coordinators, and I will hand over sessions to Dr. Sonal Panchal. So ma'am, I hand over the session to you.
Thank you very much, Dr. Nishant, for the kind introduction. Good evening, all from India. Greetings from India to all of you. It is my pleasure to start this CEFOG International Academic Exchange webinar. This is the first webinar of its kind for this year, and it's going to be a series of such webinars. This webinar is in collaboration with Iron Donald School, Iron Donald Inter-University School of Medical Ultrasound, and we are going to talk on imaging of the fetus. It is my pleasure to introduce Dr. Rohana Khatutova for his welcome address. And if I may be privileged to introduce him, he's a chairman, Nine Wells Care Mother and Baby Hospital, Secretary General Asia Oceania Federation of Obstetrics and Gynecology of FOG, FIGO Chairman, Menstrual Disorders Committee, President, South Asian Federation of Obstetrics and Gynecology, SAFOG, Vice President, South Asian Federation of Menopause Societies, SAFMOMS, past President, Sri Lanka College of Obstetricians and Gynecologists. Welcome, Dr. Rohana, please.
Sorry.
You are muted, probably.
Yes, I was muted. Thank you, Sonal, for that kind introduction. I just want to make one correction. I am not the chairman of the Menstrual Disorders Committee of FIGO. I am the past chairman of the FIGO Menstrual Disorders Committee. So,
sorry, sir.
Thank you. Dear past presidents, executive board members, and all the other members of the SAPOG, members of the Ian Donald School of Medical Ultrasound, Professor Asik, Professor Frank, and all the chairpersons, moderators, speakers, and panelists, and all the delegates who have joined for this joint SAPOG Ian Donald School webinar on imaging the fetus. This webinar is the first of the series of international webinars planned for the year 2022 by the International Director of SAPOG, Professor Narendra Malhotra. I am thankful to Narendra for planning and organizing this wonderful webinar today, involving a galaxy of stalwarts in ultrasound from the Ian Donald School and SAPOG. And he has done this in a very, very short time. And so this highlights again the great organizing capabilities and capacities of Narendra. And then I would just go on to make a brief introduction of SAPOG to the benefit of those who may not be aware of SAPOG very much. SAPOG is a South Asia Federation of Obstetrics and Gynecology, which was formed in 1996 with the South Asian countries, Bangladesh, India, Nepal, Pakistan, and Sri Lanka joining as founder members. Then later, Afghanistan joined as a member. Though not members yet, SAPOG is working closely with Maldives and Bhutan in the South Asia region. The first conference of SAPOG was held in Lahore, Pakistan in 1996, and Professor Rashid Latif Khan from Pakistan was elected as the founder president. Since then, we have been having conferences once in 2 years, rotating among our member countries, and the presidency has also rotated accordingly. So this year, we will be celebrating our silver jubilee of SAPOG, and there will be a grand congress in September this year in Sri Lanka. And I wish to invite everyone to join the conference in person. I am sure that by that time, we will be able to, there will be more liberal traveling and we will be able to meet each other. So I invite you again to Sri Lanka in September this year. I thank you, Professor Kujak, founder director, and Professor Charvana, director, Ian Donald School of Medical Ultrasound, for agreeing to the joint spread of knowledge. And I am happy to see Dr. Jaydeep Malhotra, who is a SAPOG editor-in-chief, but today she is wearing another cap from the Ian Donald School, as she has so many caps in her possession. I am happy to see, and thank you all the chairpersons and moderators, and welcome all the speakers and the panelists. So a great program is ahead of you. So I don't want to take any more of your time. So I invite everyone to participate and join and enjoy the rest of the wonderful webinar. Thank you very much. Over to you, please.
Thank you very much, Professor Rohana. And I would request Chitra to please play the Ian Donald introduction video for us.
"40 weeks, 3 trimesters. However you put it, 9 months is a long time. Thankfully, these days we don't have to wait that long to get a first glimpse of the unborn baby. Ultrasound scans, developed at the University of Glasgow by Professor Ian Donald, are painless, safe and reliable, an important way of checking that the fetus is developing normally and a defining moment in any woman's pregnancy. Ultrasound is vibration at a very high frequency. It's used in the animal kingdom by a variety of species as a tool for hunting and navigation. Scientists use sonar in a number of ways too, from checking for cracks in aeroplane wings to cleaning delicate pieces of jewellery. But it was Ian Donald who first harnessed this natural phenomenon into a visual technology that could be used to display images of an unborn baby. Born in Cornwall and educated in Scotland and South Africa, Professor Donald studied medicine at St Thomas's Medical School in London, graduating in 1937. After serving as a medical officer in the Royal Air Force during the Second World War, he accepted the Regius Chair of Midwifery at Glasgow University in 1954. Professor Donald arrived at his alma mater with, in his own words, the residue of a Leverhulme research grant, a rudimentary knowledge of radar from my days in the RAF, and a continuing childish interest in machines, electronic and otherwise. He had an idea that radar technology could be adapted for medical diagnosis. However, his early experiments on tumours using an industrial ultrasonic metal flaw detector were greeted with scepticism. Undaunted, the professor worked with T.G. Brown of the scientific instrument makers Kevin and Hughes to create the first diagnostic ultrasound machine. In 1958, he published his findings with John McVicker in The Lancet. The article was one of the defining publications in the field. Professor Donald's wait was over, and so was ours. The early days of ultrasound were not easy. Machines could only create fuzzy images at first, but from this difficult beginning, a new science of fetal diagnostics emerged. Today, machines can show the unborn fetus in sharp detail and even video images in 3 and 4D. Professor Donald would be pleased to know about these developments. Speaking in later years, he noted that the innumerable difficulties, setbacks and disappointments have been more than compensated for by those who have turned the subject from a laughable eccentricity into a science of increasing exactitude. He'd be pleased too to know that ultrasound is now used in many fields of medical diagnostics and also in veterinary medicine. Like X-rays, ultrasound allows us to look inside the body, but unlike X-rays, the technology is not based on radiation. By helping to create a safe and effective way of seeing inside our bodies, Ian Donald changed the face of medical and veterinary practice.
Medicine and science are truly global because their very nature is global. And to produce curriculum which is equally attractive for developed and developing countries was and still is the main challenge of Ian Donald School. I welcome all the new participants you will find friendly and stimulating and above all pleasurable team of first-class speakers and a very friendly atmosphere and interchange of opinions. Welcome. Donald School is now generally accepted as a success story in globalized medicine. We transcend all the borders, all the nationalities, all the religions. We have our motto, unity in diversity. This type of postgraduate, highly specialized teaching is now widespread in 132 countries, both developed and developing.
In Jan Donald School, we do ultrasound courses around the world, and we hope that we can find enough of young people that we can get interested for ultrasound. And this is indeed a very important field because we can detect a lot of malformations in early pregnancy. We can detect also a lot of malformations in the second trimester or even in the third trimester, and this can help to avoid morbidity and mortality in the neonate, and I think this is very important.
Jan Donald škola ima duboke međunarodne korijene. Jan Donald škola raste. Svake godine nekoliko novih zemalja se pridružuje. U Sjedinjenim Američkim Državama otvorili smo školu na Havajima 2005. godine. Svake druge godine održavamo skup, pretežno za liječnike sa Havaja, za naše specijalizante, isto za naše ultrazvučne tehničare, jer je u Americi to cijeli tim koji se bavi prenatalnom dijagnostikom i ginekološkim ultrazvukom. Havaji su daleko od svih i od Amerike i od Japana, ali u mnogo čemu mi vodimo u ultrazvučnoj dijagnostici u Americi i Jan Donald škola nam je važna da pokažemo svijetu da i unatoč razdaljinama ultrazvučna dijagnostika je važna za pomicanje i unapređenje zdravlja majki i djeteta. Mi smo dio jedne velike familije koju je dr. Kurjak osnovao u Hrvatskoj i koja se proširila cijelim svijetom. Mi smo vrlo ponosni na naše članstvo u toj organizaciji i jedna smo od dviju škola u Americi.
It has been my great pleasure and privilege to work with OSM during the past 30 years, building up the Ian Donald School. This is an international brotherhood and sisterhood of over 100 countries, whereby we teach physicians and sonographers throughout the world. This group is dedicated to education throughout the world. Why it has been such a success is that there's no money involved. It involves tireless and dedicated professionals who do this because they love to teach and love to share knowledge. Azim Kuryak is an organizational genius who brings out the best in people and enjoys helping them throughout the world. It's a true pleasure to work with him and to see these endeavors grow and grow in the months and years to come.
He's for us very important person. I met him many years ago. I always could count for his help. So I can say truly that now we are the friends, and I hope there will be many other opportunities to cooperate together.
It is now widely accepted that education is a lifelong process, and real education is global education. You cannot teach differently in Zagreb, Belgrade, New York, or London. So teaching is transmission of enthusiasm and explosion of new knowledge coming every day by scientific discoveries, increasing ever-growing encyclopedia of knowledge is tremendous in this modern time. Therefore, one of the main challenges in scientific and educational world is to apply appropriate teaching methods to give the best knowledge and to teach students how to develop habit of thinking instead of habit of memorizing. Virtually every 2 years knowledge is doubled. So to keep in touch with this advancement, to put all of these new theories, techniques into the practice for the benefit of our patient requires permanent learning and permanent type of success.
In 2004, JP established a strategic association with Ian Donald School designed to address the needs of a clinician who has some experience in diagnostic ultrasound, but needs additional knowledge and practice in the recent sonographic developments in both obstetrics and gynecology. Ian Donald School is a living tribute to Ian Donald, the visionary physician who pioneered ultrasound in obstetrics and gynecology. This alliance has furthered the Ian Donald School mission of promoting the science and art of ultrasound scanning through JP's print content offerings and digital knowledge solutions. The Ian Donald School's ideology of research and education is ably complemented by JP's global reach and comprehensive medical content publishing program. JP is the proud official publisher of the Ian Donald School content, including the prestigious Donald School Journal of Ultrasound in Obstetrics and Gynecology, widely known as the Yellow Journal. This association has been instrumental in disseminating the knowledge and information to students, practitioners, and key opinion leaders across the world. In 2017, JP published Donald School Textbook of Ultrasound in Obstetrics and Gynecology. JP is excited to announce the release of 3 prestigious textbooks in the Donald School Textbook series in 2017. We believe these textbooks on human reproduction, diabetic pregnancy and ultrasound, and transvaginal sonography will feature on the must-read list of every medical student and practitioner. These founding years of the alliance between Ian Donald School and JP have laid the strong foundation of a long and enriching journey ahead on the path of knowledge that we look forward to.
Thank you. Thank you very much, Anne Donald School, and thank you very much to Professor Rasim and Professor Frank for introducing us all to this huge institution doing great work with great ideologies. I would say the most noble work of spreading knowledge. I would now want to introduce Dr. Jaideep Malhotra. She is Managing Director of Air to Rainbow IVF, Vice President, Indian Society of Aesthetic and Regenerative Gynecology, Chair, FIGO Committee of Reproductive Endocrinology and Infertility, immediate past President of South Asian Federation of Menopause Societies, SAFOMS, and ISPAT, Regional Director, South Asia in Iron Donald School of Ultrasound, Professor Dubrovnik International University, Croatia, past member of FIGO Working Group on RDEH, member of Accountability Group of PMNCH, who editor-in-chief, CEFOG and CEFOMS, journals, and many books, President Rotary Club of Agra Grace, past President Foxy Isar Aspire IMS, past President and Vice Chairman ICOG. She's been credited with first 500 IVF babies of Nepal. She's advisor to the Maulana Azad Medical College, Delhi, and she's a recipient of several awards. She's also an initiator of the Club 35 Plus, Adbhut Matrutva, iMoms app, and of course, welcome Dr. Jaideep, and please tell us something about today's program.
Thank you, Sonal. Thank you so much. And a very, very good evening to all of you from the South Asian region. I am representing now as the editor-in-chief of CEFOG and also the regional director of Iron Donald School. And as you know, Rohana was saying, Rohana, this was the one of the earliest caps which I have worn, and for a much longer time than the rest of the things which you have seen. And this is all thanks to Prof. Asim, because I met him way back in 1985. And from then onwards, the relationship is going on, and such a wonderful visionary who has, brought in all the nations together and for one science, and that's ultrasound. And today, I think we are very, very fortunate that we have many pillars of this in Donald School of Ultrasound here on this platform. And I think our region is really very lucky. And today, you're going to listen to one of the most wonderful sessions where these are the speakers I would leave everything to go and listen to, and they have come in your own rooms and drawing rooms, and today we're going to interact with them on a wonderful session. It is my privilege that we have Asim, Prof. Asim Kurjak, Prof. Frank Chernovic, we have Aris, and we have our own 5 directors from India. And India is one of the largest representatives who would be talking on. And the 3 talks which we have are, again, they are fantastic titles. And when you're going to listen to, I think Prof. Asim Kurjak is always magical. But Ritsuko, who, when you're going to listen to her and look at the slides and the wonderful images which she builds up, it's going to be a treat for every eye. And Frank, I'm sure, is going to give us a very different perspective about epigenetics of fetal origin, which is one area which I am working on in the past many years. And we're looking at a panel discussion because fetal growth restriction in our region is quite prevalent, and how to diagnose and how to go about it. We have a wonderful panel which is coming up with great moderators and the panelists. I'm sure we are really looking at an absolute academic feast. So go ahead, enjoy yourself. The stage is all yours to assimilate as much as you can from these wonderful speakers. And I think SAFOG is also very indebted for all the program organizers who have actually put this feast together for all of us. And I think it's going to open up an absolutely new vista for us to interact. All the best to all of you and happy academics.
Thank you very much, Dr. Jaideep. And I'm not sure, I'm not seeing here, is Dr. Frank here or not yet?
Frank is unable to join in. He'll join in a little later. He's having some technical problems. So he just SMST, go ahead. He'll join in immediately.
So should I go ahead with his introduction?
Yes, please. Let's please start the scientific session 1 of the speakers. And before that, apologies from Dr. Rustiko Poo. She's unable to, because of some technical part, her video will not be playing today. So we'll be taking her talk in the next SAFOG International webinar. So we have 2 talks and 1 panel.
So Ankita, will you take ahead the Monisha or Ankita, will you take ahead the session 1?
Okay, thank you, Dr. Sonam. Thank you, Sonam ma'am. So we will be proceeding with our first session. And to chair the session, I'll be inviting the chairpersons, Dr. C.B. Nagori. He needs no introduction. He is the director of Dr. Nagori's Institute for Infertility and IVF, Ahmedabad. He has his best paper on World Congress ESOC 2008 Chicago. He has first stem cell pregnancy in India. He has published several papers in Index Journal. First ever Center of Excellence for Ian Donald School of Ultrasound. He has regular training in infertility, in vitro fertilization and ultrasound. Has Gujarat University recognized fellowship programs in infertility and IVF. And he has contributed in and authored several books and delivered more than 1,000 lectures. Welcome, sir. Welcome, sir. And we will be proceeding to our next. I'll inviting next chairperson, Dr. Aris. He works at University of Athens Medical School, Greece. At the national level, he is a founding member and executive board member and president of several organizations in the field of obstetric and gynecology, perinatal medicine, ultrasound, and fetal medicines. He's a member of expert advisory panel on maternal and perinatal health and obstetric FIGO since 1997. He's a president-elect of the European Association of Perinatal Medicine, president of the 19th European Congress of Perinatal Medicine, Athens, October 2004. He's a past president of EAPM for 2004 to 2006. He's a member of the International Academy of Perinatal Medicine, vice president of the Mediterranean Union on Obs and Gynae. I welcome you, sir. Moving to our next chairperson, Dr. Hesham Arab. He has graduated from Riyadh University, obtained his fellowship in obstetric and gynecology from Canada and USA, the first Saudi doctor specializing in fetal medicine, a consultant in obstetric gynecology, fetal medicine, and laparoscopy and infertility surgery, and the first surgeon to raise the bladder neck with the tape to treat incontinence. He performed the first laparoscopic hysterectomy in Saudi Arabia. Founder of the first ultrasound course in Saudi Arabia, Dr. Hesham received the title of scientist for the year 2002 from Cambridge, Britain, in recognition of his achievements and for being one of the first researchers in the world to detect Down syndrome before his birth and other. He is the owner of the annual Dr. Hisham Arab International Prize for Laparoscopic Surgery since 2016, to be awarded to be the best laparoscopic surgeon at the annual meeting of the International Society of Gynae Endoscopy. I welcome you, sir. And I'll request our chairpersons to introduce our speakers.
Professor Aris, can you introduce Asim? Professor Antakles, can you introduce the first topic in Dr. Asim?
Yeah, okay. I thought that Dr. Nagori is going to present, but anyway. It's my pleasure and my honor to present Professor Kuriak. Since Professor Kuriak is the founder of Fiandona School, he's a very good friend I know him since many, many years. We work together, and I think that he's a professor emeritus at the University of Sarajevo, president of International Academy of Prenatal Medicine, president of International Academy of Science and Art in Bosnia and Herzegovina, published about 1,000 more papers, founder and director of Ian Dolan in the University School of Medicine of Ultrasound, editor-in-chief of Donald School Journal of Ultrasound and Obstetrics and Gynecology. He's been awarded Doctor Honoris Causa from 13 universities worldwide. But it's very important that Asim Kuria is my very good friend. So, ladies and gentlemen, as I told you, it's my honor to present Asim, and he's going to talk about neurodegenerative evaluation of the fetus. I think it's a very interesting topic, and I'm sure that Asim is going to present in a very good way. So please, Asim.
Chitra, can we play his recorded speech? Professor Asim Kuriaks.
What is history, definition, and concept of fetal behavior? I repeat some of the thoughts because this is very, very important. First of all, what is fetal behavior? There are many definitions. If I took linguistic definition, in English, it is the way in which someone or something behaves. And that can be accepted by some of you. Scientific, however, definition said that fetal behavior can be defined as any observable action or reaction to an external stimuli by the fetus. Or, a little bit simpler, behavior is the interaction of an organism with its environment. This is probably, for practical, is a good one. So, there are three ways to study fetal behavior: passive observation of activity, recording reaction of fetus to a stimulus, and by fetal habituation. Hand-to-head movement we published long time ago, 17 years ago, hand-to-head mount base, all of them detectable and are part of our scoring system now. On the face is, as I said, mirror of the brain, predictor of the brain. It is reservoir of many important neurological parameters. Freud said on the face there are 17 face muscles. If you are lucky and happy, you'll be using 4 muscles. If you are grimacing, if you are angry, you have to use 17 muscles. So message is, why make so many muscles busy? Don't worry, be happy. So on the face, we have yawning, swallowing, sucking, smiling, tongue expulsion, mounting, and so on. All of them described in literature, all of them part of our kind of system. So what is fetal habituation? Is decrease leading to cessation of behavioral response that occurs when an initially novel stimulus is repeatedly presented. So learning. There is fetal habituation, a Japanese group published to virtual vibration stimulation, and habituation is widely accepted as a basic expression of fetal learning, memory, addiction, abilities, temperament, and fatigue. So all these 6 parameters, 6 topics can and are now already studied to understand the process of habituation. We have fast and we have slow habituation. There is a good evidence that normal habituation pattern reflects an intact and fully functioning central nervous system. So it does study of habituation tell us about functioning CNS. Why all of this is important? Because if behavior is product of functioning CNS, ultrasound evaluation of fetal behavior with 4D method will help us to prenatally diagnose abnormal behavior patterns and possible diagnosis of fetal brain function and dysfunction. So if you look at the baby at 28 weeks, unborn baby, you see what is said in all textbook in our secondary grammar school or even at the university, that unborn baby doesn't listen, doesn't watch. Both of them are wrong. Noise in utero is 70 decibel, as busy as strong as busy Istanbul street. And baby starts eyelids opening as early as 24, 26 weeks of gestation. And we now know which parts of brain are responsible for movements. Ladies and gentlemen, it's take-home message. To research is to see what others have already seen, but to think what others haven't thought. So science is discovering something new. In science, there is no good and bad work. Scientific results are called scientific discoveries. They immediately go to knowledge. So science is process of discovering new, and knowledge is increasing every day by scientific discoveries. I am very keen in fine art, and I have, you can see behind me in my study room, many valuable paintings. It's very interesting. They build artists like old Spanish masters, Murillo, Velázquez, Picasso, and the others, use the face to express feeling, character, to visualize, memories, emotions. So face stimulated big artists to do this. We are somewhat artists with 3D, 4D ultrasound, because again, largely neglected organ for us in ultrasound work, face was neglected for a long time. Now face is subject to great intensive research because every day we discover something new. So obviously medicine is science and art. Medicine combines science and art. If you look at this combined picture, we have beautiful artistic pictures of famous painters, and we have somewhat artistic pictures of unborn baby. We are producing such a nice photo that not long time in advance, we will be able to produce passport photo from antenatal period, entering Turkey without visa. My friend and your colleague, Professor Milan Stanojevic, who is working with me for last 30 years, said, Professor, I'm going to watch your antenatally examined fetuses and their behavior. I will put when they will be born in intensive care unit room, video camera, and I will see how they do behave, trying to answer, is there continuity between fetal and neonatal behavior? I will show you lovely examples from his already published studies. So you will not do obstetric sonography, most of you, but you should know that visualization like this one, with 5 fingers and adducted thumb, just this will give you 95% probability that that baby is neurologically normal. Baby with cerebral palsy will not show thumb. Thumb will be covered by the fingers. Next parameter is yawning. Even adult physiologists do not know why yawning exists. Is it sign of sadness, of tiredness, of happiness? Nobody knows. But whatever pathophysiology is behind, I hope, ladies and gentlemen, no one of you in the conference hall or at your home do exhibit this parameter. Not yet.
Not yet.
Thank you. So there are many reasons to be unhappy in utero. 150 diseases affect fetus in utero. So baby has right for grimacing, but baby watch. So you see this lovely baby and fetal vision, we know, is the last sense to develop. But very premature infant, you know that better than me, can see light and shape. Does the fetus have the same ability? Japanese scientists have been reporting distinct fetal reaction to flashes of light shined on the mother's baby. But may I ask you, going home and think about, does this baby like to communicate? Is there any message baby like to send to us? Is this baby at all aware of its existence? So fetal awareness is a new hot topic studying cognitive function of the brain. Does the baby smile in utero? This happy boy from Zagreb. Now we can really visualize smiling in utero. To visualize, however, doesn't mean to understand. We are still working hard to understand other emotional stimuli, or is it just a reflex? Does the baby cry in utero? You know, the Chinese still believe that they are 9 months older than we. They add to chronological age antenatal period. Watching all of these fetal activities, I think Chinese are right. Life starts much earlier than we used to believe. If you find this baby with fixed position of the hand, all other parameters have been perfectly normal. Normal size, normal gestation age estimated. Everything was perfectly normal. But baby at each examination had fixed position of the hand. So 32 weeks, anencephalic baby, no movement at all, mumia. However, if you look the same baby at 19, 20 weeks, you will see very dynamic, chaotic movements. So we learned the lesson that there are two centers for fetal movement, upper and lower. So when the lower one is active at 14 weeks, we will have hypertonic movements, high amplitude, high speed in utero. But the same baby at 30 weeks, one of patients in Pakistan for religious reason didn't like to interrupt the pregnancy. There are no movement because there is no upper center for movement in an encephalic baby. So that was a little bit nice contribution to ever-growing encyclopedia of knowledge, you know, to understand the presence of upper and lower limit of anencephalic baby limits for movements. In all our 11 cases of cerebral palsy, we found adducted thumb. So thumb covered by the fingers, and whatever you do, you cannot, that baby had bilateral hydrocephaly, you cannot visualize thumb. And thumb is not adducted, we call it neurological thumb, present in all cases of cerebral palsy. Therefore, wherever you screen for neurological problems, do study fingers and show them with adducted thumb. Study of Professor Stanojevic, you see the baby in grimacing in. You see how lovely picture, similarity between antenatal and postnatal. As I said, passport photo can be obtained one day from pictures. So you see grimacing of the baby in utero, and you will see that the same grimacing this baby will exhibit, you know, in neonatal intensive care unit. This baby was already shown to you, smiling baby, and the same happened in neonatal period. Sorry, some technical problems. Always, this is my advice to all doing obstetric ultrasound, normal finger movement. But to finish this, Milan Stanojevic confirmed that there is continuity between fetal and neonatal behavior. All the facial expressions, all behavioral pattern we found in antenatally with ultrasound in fetuses have been repeated in neonatal period. So we speak really about the same person in two different parts of their life. So this is normal finger movement. If you can visualize it, so much the better. Or independent movement between two fingers. Picture upper, look. If you see 5 fingers and independent movement between 2 fingers, you can be 99% sure that this baby has no neurological problem, at least not serious, not cerebral palsy. So another parameters are face, facial expression, and isolated leg movements. So you see how 4D sonography improved. Not only you can visualize beautifully all anatomical components, but you can see movements, whether on face, mounting, finger sucking, yawning, crying, smiling, and isolated leg movement. Combination of the tongue exposure, naughty boy from Zagreb. So you can combine facial expression, most important, with isolated motoric on the leg and on the arm. So that was the first test that aimed to evaluate in structured and systematic way functional and structural development. And this is in summing up FANE test. You know, we produce 3-point scale systems, 0, 1, 2, 3, and studied isolated head, anteflexion, blinking, and all of these parameters which I showed you, or at the periphery, isolated leg movement, isolated hand movement, finger movements. Any one of you who are a little bit familiar with ultrasound, in 1 week can learn this test. You don't need to come in Zagreb, go to Ankara, to Dr. Setash, and we will be happy to offer the training. Is there any competitor to ultrasound? Yes. This is picture of ultra-fast magnetic resonance. You can see a lot, but what you cannot see face. Furthermore, no one on the earth will give 4 million euros to buy magnetic resonance if for 100,000, 10 times less, much less, you can buy 4D machine. So furthermore, magnetic resonance is nobody proved that it is safe in pregnancy. Above 3.5 Tesla, it's not recommended in America to be used in pregnancy. Important to remember. So while we are examining early fetus, total fetal behavior, and face by 4D, you know, your duty is to examine newborn with the methods which should be improved to reach better reliability and better accuracy. So our test was tested because if you pretend to have something which one can name by your name, you really have to prove it to many critical colleagues, critical batonists, and they did it. So CANET is a reliable method to be used in daily clinical practice. After proper education, we have 1 week course, intensive course in Zagreb, and we'll soon have in your country. So it's screening test for the detection of neurodevelopmental disability, and I might remind you, the only test available. All other tests performed in pregnancy are detecting fetal hypoxia. And fetal hypoxia is only 10% associated with cerebral palsy. So CANET test should be applied actually to all pregnant patients, and after 10, now 12 years of application as a research tool in many studies, it was concluded that it is ready for use in daily clinical practice of follow-up of fetus at neurological list. And it has sensitivity and specificity, good, positive, and negative predictive value. And also, there is strong recommendation for postnatal follow-up And it's your duty and duty of adult neurologist until the age of 3 years. If you look, these lovely twins, one of them lost his socket. Another one is trying to tell him. They do have their own language, obviously. You will like another one, which happened during quarantena.
Thank you, Dr. Asim, for such an amazing session. I'll request the chairpersons for their expert opinion after such a wonderful lecture.
It was an excellent talk by the professor, and he always gives us something new, always in his talk. I think my colleagues would like to opine for the same.
Yes, I totally agree. Professor Kuriak has always been on the forefront for the new inventions and developments in our fetal medicine. Actually, the Canet test has tried it myself, and it's really working nicely. I think with the spread of this knowledge, we can have maybe more assessment of the fetus for fetal well-being in the future and having healthy babies.
Can you introduce, and I now introduce Frank. Somebody has to say, no? So, should Professor Hisham, will you please introduce Dr. Frank?
Sure, I will. Okay, well, it's really my great pleasure and honor to introduce our next speaker, whom I've been knowing for the past 20 years, and as a dear friend, and also we have good relation with family-wise. Also, I have the pleasure to meet him very, occasionally and often in New York, and he is actually the chair of obstetric gynecology of Lenox Hill Hospital at Lenox Hill Hospital, Gynecology, Associate Dean for the International Medicine Zucker School of Medicine at Hofstra Northwell. He's a member of the board governor of the American Institute of Ultrasound Medicine, Society of Perinatal Obstetricians, the Ian Donald Inter-University School of Medicine and Ultrasound, World Society for Labor and Delivery, and World Association of Perinatal Medicine. Professor Chevernak actually has served as a president of the International Fetal Medicine and Surgery Society. He's also New York Perinatal Society past president. He also a New York Academy of Medicine section of Obstetrics and Gynecology, and now he's an International Society of the Fetus as patient, actually well known in this field, and we always love to attend his meetings where actually these congresses as showing an elegant knowledge in this field. It's my pleasure to introduce Frank to talk about the role of epigenetics in fetal origin of adult diseases.
Chitra, can we play the video of Dr. Frank, please?
Yes, ma'am. 1 minute.
To Zoom from very cold New York, a warm greeting to Narinda, Jaydeep, and all of my many, many friends in India. I'm sorry I can't be with you in person, but I'm sure you understand. The COVID-19 pandemic has subsumed all of us, and that's why I've modified the title of my presentation to discuss this important topic. I have no disclosures, and in my current position, I'm chairman not just of Lenox Hill Hospital in Manhattan, but of several hospitals throughout Long Island and Westchester. And it has been the epicenter of where COVID has begun and where it is today in the third year. I want to start off by saying the year 2020 began very well for our Ian Donald School when we were in Jeddah, in Mecca. Here you see a beautiful slide. But when I came back on that plane ride on March 1st, I was very shocked to see the New York City that welcomed me. The city that never sleeps went into hibernation. And indeed, my wonderful department was in a state of shock. A beautiful church across the street, which was always packed on Sundays, was empty. And this quote from Thomas Paine, an American patriot, in the darkest moments of our American Revolution, I sent to my entire department that these are the times that try men's souls, because what hit us was unbelievable. We had to learn new concepts during that spring of 2020, such as flattening the curves. I was fortunate to work in a system where we met once or twice a day throughout our whole network and learned a whole bunch of new concepts. It was an exponential increase in COVID-19 patients. And as you can see here, we were caught short from the supplies that we needed. There's no greater symbol of the shock that we felt with outside one of our entrances. You see the refrigerated hearse because the morgues could not accommodate all the dead bodies that occurred. I lost one of my older doctors during this critical period. Now, we almost had to relocate our entire obstetric service out of the hospital because COVID-19 was occupying our entire hospital. Now, this was not something I was eager to do because this would jeopardize obstetric care. And indeed, this could have caused a risk of maternal mortality and morbidity. The concept of frame shifting is something we put forward. This was a public health emergency, and I was prepared to do it. Fortunately, at the last moment, literally the 11th hour and 58th minute after we had started packing, we got the message we didn't have to move. Another important concept ethically that we put forward was ring fencing. By that I mean, this was a concept that was developed from Great Britain, where you protect vulnerable features. This started with animals. It can be used for financial aspects. But when we said no elective surgery, some states in the United States said, well, then you can't do elective abortions. We said no, elective abortions were allowed to continue. Now, I want to emphasize self-sacrifice is an important ethical virtue, but we had to obtain the important protective equipment for our doctors and nurses and healthcare providers. This was important. Planned home birth is not a good alternative at times of crisis, and we should recommend hospital births. And we have data to show the problem here. We showed that when there was, at the height of the COVID-19 pandemic, there were more breech deliveries and more low APGAR scores that occurred during this critical period. So it's been argued if you have more home births, there was more patient safety. It was the exact opposite. A theme that I have argued for so strongly, births should occur in the hospital when there are the resources to provide for this. Another ethical term is that births should be accompanied by a spouse or partner, as long as there are the resources to do so. And we disagreed with some of the other departments in New York City that went against this. One of my charges here at Lenox Hill is that I'm in charge of the ethics committee. And we had to discuss an unpopular concept, triage. Fortunately, we didn't have to invoke triage. That means turning patients away, because we were able to expand capacity. And fortunately, we did not have to turn patients away. The light of the end of the tunnel came when the vaccine was finally available and able to be for our pregnant patients. As early as February 2021, we strongly advocated that pregnant women should have this, because COVID-19 infection is a disaster for pregnant patients and for the soon-to-be-born patient. There is no risk to the fetal patient, and any risk to the mother is negligible. So as a result, it should be done. Unfortunately, there were severe delays with professional societies in the United States in making this recommendation. Here we see examples of mothers who died because they did not get the vaccine. Fortunately, finally, on September 29th, our CDC published a health advisory recommending the COVID-19 vaccination for pregnant women. Finally, and our professional societies recommended it, but it came too late. Anthony Fauci and our group from Northville recommended this in February. A big problem we've had in the United States is not just patient hesitancy, but physician hesitancy, and we have to address this. Professional ethics should guide reversing 3 root causes of physician hesitancy: clinical misapplications of therapeutic nihilism, therapeutic misapplications of shared decision-making, and clinical misapplications of the ethical principle of respect for autonomy. Therapeutic nihilism is important. It has its roots from the time of Hippocrates. There were disasters in obstetrics from thalidomide and diethylstilbestrol, and it made us realize we have to be very, very cautious in not putting forward medications. However, the increased risk of maternal severe illness, ICU admission, and maternal, fetal, and neonatal death were already well documented early in 2021. There were no documented theoretical risk of maternal, fetal, or neonatal harm, and there were no documented increased adverse outcomes in vaccinated pregnant women. Shared decision-making has an important role in decision-making with patients when evidence is uncertain. It's misapplied when it's the sole role for decision-making. For example, if you leave this lecture and you go back to labor and delivery, and there's acute fetal distress, I hope you're going to say, you need to do an acute cesarean delivery, not what would you like me to do and have a long discussion. So a second root cause of physician hesitancy is to have a long discussion by only offering but not recommending a specific management. Shared decision-making was the dominant form of discussion for too long. Back in February 2021, the dominant form of decision-making should have been directive counseling, and our professional societies took too long in making this recommendation. All of our professional societies now should call for a clear recommendation. Respect for autonomy plays an indispensable role in decision-making with patients, but is misapplied when making recommendations is considered incompatible with respect for autonomy. Pregnant patients report that their physician's recommendations were the most important factor in their decision-making, especially as it relates to recommendations to get COVID-19 vaccines. It follows that making recommendations empowers pregnant women to make informed decisions, belying the view that making recommendations is misapplication of the ethical principle of respect for autonomy. It's essential that we all reverse the three root causes of physician hesitancy, whether we're in New Delhi or New York City. Obstetricians and those in leadership position must end physician hesitancy about COVID-19 vaccination by reversing these three root causes. Physician hesitancy should not be permitted to influence the response to future epidemics. Pregnant doctors should proudly show that they get vaccinated. It's important that all of us in India, the United States, and elsewhere advertise this. We have shown this in our hospital and throughout the United States, and this is advertised. I'm very proud, look at the left-hand slide, that 60 Black health experts advocated that Black Americans get vaccinated. We have a particular problem in America that you don't have in India. We have an ugly history of the Tuskegee experiments, where Black patients were experimented upon with syphilis. And as a result, Black patients are sometimes afraid to get vaccination. We must eradicate this hesitancy. Look at the right side. I'm very proud that our Chief Executive Officer, Michael Dowling, sends out a Covoid crusher, making us proud that all of us got the vaccine. I'm very proud to work in an organization that has zero tolerance, I repeat, zero tolerance for everyone must get vaccinated. It's unacceptable for anyone not to take the vaccine. No bogus religious excuses. This is nonsense. The only medical exemption is if you have a severe allergy to the vaccination. This is unacceptable. One of my doctors, I'm ashamed to report, refused to take the second dose of a vaccine. He was not allowed to have privileges, and I'm proud of this. Now, before I go on to this, I want to say we are undergoing a time of reduced crisis here in New York City, where we have a recrudescence of Omicron. And by that I mean, it's not as bad as it was a year ago when we were considering moving our whole obstetric service out of the hospital. But currently 25% of all of our obstetric patients are testing positive. And many of our staff are testing positive, and as a result, they are quarantined. And my administrator and myself are struggling to make everyone, we have to fill the gaps and provide the service. The good news is patients are not, and our doctors and nurses are not getting seriously ill. Only one patient had to go to the ICU, and this was a patient who was unvaccinated. And this is pretty much reflecting the national experience. The only ones who are getting seriously ill and die are those who are unvaccinated. And I can't emphasize to all of you in India, use the strongest form of directive counseling with your patients and your families and friends. Take the vaccine. Some good news. Our Northwell Choir, I'm especially proud of. These are amateurs. They sung at the White House. So they're good moments of what has happened. I'm very proud of our international society, which Narendra and Jaydeep are our new national representatives of India, our International Academy of Perinatal Medicine, our Ian Donald School, our International Society of the Fetus Patient, our World Association of Perinatal Medicine. But there's been a moratorium for 2 years. We hope 2022 will bring us together. I say this clearly, that COVID-19 will fade, our international societies will endure and thrive. It is a thing of beauty that we can continue to communicate with Zoom, but it's much better to be in person. I look forward to visiting your wonderful country once again. I thank you for the privilege of being with you. Thank you and have a wonderful day and a happy, happy New Year.
Thank you, Dr. Frank, for such an amazing and enlightening session. I'll again invite the chairpersons for their expert comment.
It was a very good talk, very informative, and really this is needed at the time of COVID. I think my colleague will also give their opinions.
Certainly, I really would like to thank Narendra and the organizers for this excellent gathering. The SAFOG International Exchange webinars are on the first go, and I think it's so successful. Happy to join, and also to hear from two eminent speakers the last two lectures, especially the last one by Frank on the current situation, and I'm really would like to support his call for extending the vaccination to pregnant women with safety and with the really reassurance for all our pregnant women. So this is a great message, and I'd like to support it and for all of our patients. Thank you.
I would like also to thank Asim and Frank for their contribution to this excellent meeting. And I think what Frank said about COVID-19 is very important. And vaccination of pregnant women is a must. And we advise all pregnant women in Greece just to have a vaccination. But I would like to congratulate Naren for this excellent meeting, and also all the participants. And I would like to thank you very much.
Thank you to all the chairpersons and the speakers. So here, ending to our first session, we will be proceeding to our next session on the panel discussion. Monisha, you are here?
Yeah.
Okay, so over to you, Monisha.
Thank you so much, Dr. Ankita. Welcome everybody for whoever have heard the first and second session. It was wonderful indeed. And thank you so much, Dr. Ankita, for this wonderful and magnetic session. Such is the power of the knowledge. If these sessions do not push you to learn 4D scans, I don't know what will. So the theoretical knowledge is all good, but when it comes to the practical and how to approach such a case is the key to all. And this is where a power-packed panel discussion comes to being. IUGR is an important health problem of the developing country around the world. So there are multiple causes, as we all know, including the maternal, fetal, and the placental and the genetic factor. So to get into the glimpse of how this fetal growth restriction and well-being, we have esteemed panelists from across the globe. And moderating this session would, and with the head-scratching case scenarios, would be Dr. Shresht and Dr. NM sir. So Dr. Suresh sir, we welcome you. Sir is an honorary FRCOG and a director from Mediscan System, Chennai, India. Is an honorary secretary at the Voluntary Health Service and a visiting professor in perinatology, SRMC, Chennai, and PSG Hospital, Coimbatore. He's a fetal medicine specialist with an experience of 39 years in ultrasound and had been conferred of FRCOG, is an SIS-UOG BT task force member, an ambassador to India, trained with fetoscope and laser in Necker Hospital, Paris, and has a main interest in prenatal diagnosis and fetal therapy and ultrasound education. We welcome you, sir. Dr. NM sir, Naren sir needs no introduction, most humble professor of all. He's a managing director of the Global Rainbow Healthcare with the director in ART Rainbow IVF, Manyata CSC, Project Positive Health Rotary District of Agra, has been the director of International Relation of SAFOG, and a director of Ian Donald School of Ultrasound with Sarajevo School of Science and Technology, Croatia. He has been president in SARG and past vice president of SAFOG and WAPM, has been the past president of Rotary Club, has been past president of Foxy.
Thank you, Monisha. Thank you. That's enough.
Thank you, sir. And we welcome to all the panelists that we have like brilliant panelists to there, and would like to introduce them all. Dr. Sami sir. Sami Mohammed has been a consultant of OBS and Gynec from Sudan with the care of Reproductive Healthcare Center, has been an honorary Secretary General at African Federation of OBG, has been a Secretary General at the Sudanese OBS and Gynec Society, has been president of the Advanced Life Support in Obstetrics. Next. Dr. Ashok sir, our humble professor, he's been the chairman and consultant in the reproductive ultrasound at the Ultrasound Lab, New Delhi, has been trained in Denmark, president-elect of the Society of Fetal Medicine, has been an Indian ambassador of ISUOG, has been a member of Foxy Genetic and Fetal Medicine Committee, has been a former president of the Indian Federation of the Ultrasound in Medicine and Biology, Delhi chapter. We welcome you, sir. Dr. Wahaj, sir has been born and brought up from Pakistan only, has been MBBS from Karachi, MCPS from Karachi itself in the radiology department, has been a visiting fellowship in the ultrasound from Jefferson University Hospital, USA, has been a director in the ultrasound imaging in the Peshawar and Kabul. He has been the director of Afghanistan branch from Jefferson Institute of Ultrasound and Research, has been a member of American Institute of Ultrasound in Medicine and Biology, and was president Imaging Society of Afghanistan, has been also the director of Wahaj and Afghan National Army Institute of Medical Science in Kabul, has been a director of Ian Donald International School of Ultrasound from the Afghanistan branch. We welcome you, sir. Dr. K.V. Sridevi has been ma'am has been a fellow fetal medicine and FICOG, has been a diploma taken a diploma in advanced obstetric ultrasound from the RCOG UK, and also in the fetal invasive procedures from Italy. Has been a consultant in the Pinnacle Hospital of Visakhapatnam and is current director in the South region of the Ian Donald Ultrasound Training Program. We welcome you, ma'am. Dr. Selva has been an MD Gynec and has actually been a faculty member of ICMCH since '94. Has been conducting Foxy ultrasound certificate course since '94 and conducting reproductive medicine course for IMA since 2009. Conducting training in the Ian Donald School of Ultrasound in Tirunelveli and presented in many paper and chaired many sessions. We welcome you, ma'am. Dr. Sonal Panchal has already been introduced. I hope she'll be there for the session. Next, Chitra. Dr. Ebroshi, sir. Sir has been a professor in Cairo University of Qasr Al-Aini Hospital, has been a deputy director of fetal medicine and in the Cairo University, has been consultant in the ultrasound and fetal medicine in Giza, Egypt, and currently in the WAFI Center in the Cairo, Egypt. Dr. Deepika ma'am is an MS FMAS and Masters in Ultrasound Obs and Gynae from the Ian Donald University itself, and has been currently working as a fetal medicine consultant in the Femi Care Hospital, Hyderabad. Dr. Shrestha sir is an MD PhD, is a consultant radiologist in the IVF department in the Om Hospital Research Center Private Limited and the Kathmandu, has been a director of Nepal branch of the Ian Donald School also, has been awarded with the prestigious Mahendra Vidya Bhushan Award in the Nepal, has a special interest in prenatal screening, genetic diagnosis, obstetric and gynecology ultrasound, along with the interventional and ART related ultrasound, has completed many courses in the fetal ultrasound programs over 2 years and published over 20 scientific abstracts and 6 peer-reviewed papers. Dr. Kuldeep Singh, sir, is already a master trainer in his field of ultrasound and has practiced ultrasound in New Delhi and had more than 300 talks, national and international platform, had been invited over many countries, received more than 4 awards and gold medals in the field of ultrasound, and has authored many books. And,
thank you, Dr. Monisha. Let's go ahead. Thank you. Thank you so much.
Thank you so much. So we'll proceed ahead with the moderator sessions and the questions. Dr. Shrestha sir. Shishadri sir. Thank you, sir.
Are you able to see my screen?
Yes, sir.
Yes.
Okay. Good evening and welcome to all, and thank you for inviting me to moderate this panel along with Naren. We have a distinguished panelists that have been introduced, and the topic today is going to be fetal growth restriction and fetal well-being. The whole idea is to give a sort of a overall view about identifying the growth restricted fetus, and then once when they go through the pregnancy, what is it that we need to do, how to follow them up so that we can optimize the outcome. So the primary concerns we have, we know that fetal growth disorders are the most common issues faced in day-to-day care. The tools for assessment of fetal growth we have and Doppler is widely varying in practice despite guidelines being in place. So you give a set of parameters to one person, they tell you this is what I will do, and you give it to another person, they will give you a completely different opinion. And one of the most common things you say when the patient should come for a repeat scan, for example. And there is new evidence coming all the time. And so we need to look at certain case scenarios. We start off with some screening scenarios, screening for growth restriction, preeclampsia, diagnosis, interpretation of Dopplers, and how do we translate evidence into clinical practice. So we know that for fetal growth restriction, we want to prevent morbidity and mortality. Early diagnosis, appropriate monitoring, and timely delivery is the absolute key in this area. So let's go with a case study, and I will throw it open to the panel once I tell you the case. She's a 33-year-old primary gravida referred for a scan in the second trimester. According to her LMP, she's 24 weeks, but her fundal height appears to be 20 to 22 weeks. So these are the parameters which are shown. So I'd like to now call upon, maybe let me talk to Sridevi. Can you tell us how do you interpret this, these numbers? Hello? Am I audible?
Dr. Sridevi, you'll have to unmute yourself, Jay.
Yeah. Good evening, sir.
Good evening.
By the scan, by her LMP, she's 22 weeks, but the scan is corresponding to 18 weeks, and all the parameters for the gestational age are less than 5th percentile. Yeah. But even then, I would like to see her old scan reports of early pregnancy. So the first thing is whether her dates are correct or not. So if any date correction is there or not.
So by LMP age is 22 weeks, ultrasound age is 18 weeks. You are saying that
Yes.
we cannot label this as fetal growth restriction?
Yes, because I want to see whether there is a date correction is there or not. Because that's most common thing in our population. They may not be very accurate with the LMP gestational age.
My other panelists, do they all agree with it? Kuldeep?
We would need to definitely get hold of a dating scan so that we're sure of whether is she corresponding to 18 weeks or she's supposed to be 22 weeks and now she's at 18 weeks.
So everybody agrees that we cannot label this as fetal growth restriction, and we need a dating scan. So to reconfirm whether it is a correct date, I'm going to give you a number of options here. Will you ask for the early scan, or you correct? Why can't we correct the date using the current scan? But will you correct the dates using the current scan only if early scan is not available, and rescan in 2 weeks to see whether dates are correct? Dr. Sami Mahmood, would you like to take this question?
I think Dr. Sami and Dr. Ala Abreshi are not there.
Okay, then Ashok.
I can't see them. So Ashok, maybe Ashok, you can answer.
Yes, so we have a situation here where the best reliable method of assessing how old is this baby would be to study an early scan. And so I'd request her to, whether she can produce even a scrap of paper or just a good image, then I'll check the quality of the image, see how reliable it is, and I would then use that as a dating scan, because dating in the first trimester of pregnancy is far more accurate than dating in the second trimester. I will then go on to apply that parameter to how I would interpret the parameters in this particular scan. Will I correct the dates using the current scan? Definitely no. I would be absolutely unsure on where I stand, and I would at least then think that I need a follow-up. Plus, I would, of course, look very carefully to see whether I find any evidence of an anomaly, whether I find any evidence of an intrauterine infection, and perhaps if I have a terribly deranged Doppler in this situation, such as the uterine artery, then I start thinking that maybe I'm looking at an abnormal situation. And even if I didn't have the early scan, I wouldn't correct the dates at this time. Rescan in 2 weeks to see whether the dates are correct, a definite possibility if I have no other choice. But I'd look and I'd look and I'd look even for a scrap of paper to find out whether there's any evidence of dating earlier.
Okay, one thing we just picked up, what you said, Ashok, was that you would look for the Doppler to see whether there's a Doppler abnormality.
Yes.
And supposing there's a Doppler abnormality, will you hesitate to correct the dates?
I would still not correct the dates, but I'd be very, very careful in following up this pregnancy.
Okay. Okay, Gigi, what would you do?
Also, I won't correct the date with the single scan. I'll just try to pick out when was our LMP done.
No, in these choices which I've given,
yeah.
What are the choices you would choose?
I would look at her when her pregnancy test was done, and later on follow it up whether she had any quickening, or in between look whether she had done any scan, or I would try to adjust it with the clinical parameters. When she was seen by an obstetrician, what was the symphysia fundal height, whether it was corresponding, then all these things can be done. So that we can come to a consensus whether, like, at least whether if she has not done a previous scan, whether her clinical parameters were corresponding.
Okay, so as Ashok said, certainly you look for an early scan and you will not correct the dates using the correct scan. But if early scan is not available, you could consider correcting dates of the correct scan, provided your Dopplers were not abnormal. And then, of course, rescan in 2 weeks to see whether dates are correct. Yes, we can rescan in 2 weeks, but she's already 20 plus weeks. We need to come to an answer now. So all the time, as Gigi said, go back on the entire history, pick up something which will help you to identify whether this scan is normal, whether the dates are correct or not. But the question is, if you have an early scan, which is the best time to date? I've given you a number of images here. Which do you think will be the most optimal time to date the scan? Who would like to take this? Is anybody available? Dr. Shrestha is available here?
Dr. Hari, you can talk. Dr. Hari?
Yeah. So, you see here 10 week to 13 week plus 6. This is good for NT scan. NT scan, and here in first picture 5 week, this is gestational sac. This is correct for the early intrauterine pregnancy to see the gestational sac.
Yeah.
And
we just,
sac, you can see yolk sac also here.
Yeah, we just want
which
to know
which is the best scan to do the
dating.
Transvaginal scan is best.
No, which weeks? Which
of these?
Which of these?
You choose.
All these. Which one would you use for dating?
Yeah, 8 weeks is best. Now you can see here CRL. It's the best time to do the dating.
The dating.
So Naren, would you agree with that? Naren?
So once we date at 8 weeks, and if it is corresponding to the LMP within 1 week of difference, we leave the LMP dating as a true, and then do not change the EDD. So once you have dated, if it is more than 7 days, then we take the ultrasound and date it at 8 weeks, and again do not change the EDD. So one single scan at 20 weeks is not going to tell you anything. The dating has to start from 8 or 9 weeks.
Yeah, since this is a very important step, I would ask Sonal also to pitch in and help us.
Sonal had to leave, so we can ask Deepika. So we can ask Deepika.
Deepika, okay, Deepika.
Our young joining from the from fetal medicine.
Yeah.
Deepika, are you there? Unmute yourself and say.
Dr. Deepika is not able to unmute herself. She's mentioned in the chat box.
Please, Chitra, give Deepika unmute rights.
Okay, so let me come to the next question. So let me.
Sir, done, sir, already.
Okay. Deepika, are you able to hear me?
Great, Deepika, so go ahead.
Okay.
Deepika, you can do that now.
Okay,
Yeah.
so the best time to then, as Shrestha said, yes, 8 weeks is a good time to do the dating. But as per ISWAP guidelines, CRL of 32 to 80 is probably the absolute best. Here we have the advantage. Yeah, I'll come back to you. CRL of 32 to 80 is good. So the case conclusion here, fetal growth restriction, everybody agrees no. Wrong dates, yes. Now question is, what about dating in pregnancies undergoing ART? Deepika, can you take this question? If you want to date the pregnancy in patients undergoing ART.
Anyone? Dr. Kuldeep, how will you date ART pregnancy?
See, again, it depends on what sort of a transfer is being done. So you'll have to realize it, whether we are going to be adding on 2 weeks or are we going to be adding on 18 days to it. So really decide on, depending on a blastocyst transfer. So one will always have to figure out which day the embryo transfer and what stage that has been done. Though the ART is always much more accurate in terms of dating, because here you're not dependent on the patient's LMP or any other, you know when the procedure has been done.
Yeah. Okay. So
can I add to this?
Yes, Sridhar, yes, please. Yes.
Yeah, most of the time we put the embryo transfer date because usually they do day 5 transfers. So we usually take 19 days behind from the embryo transfer or 16 days from the embryo transfer date. But luckily, most of these patients will have early pregnancy scans with their own IVF centers when they come to us even before the NT scan. So if any slight variations, we can go back and see, because the confirmation scan after beta HCG, I think 100% of the IVF centers do the scans for them.
Yes. I know. So the moral of the story is very simple, that before even thinking of growth restriction, unless you have your dates perfect, you cannot even look at what's happening later on, and you're bound to have a lot of errors. So next we move on to 4 key questions. First, definition of a small baby. Is small synonymous with fetal growth restriction? Best fetal parameter to diagnose FGR, and best method to diagnose FGR. Now, Deepika, can you tell us about the definition of a small baby?
Hello, sir.
Yeah.
Am I audible, sir?
Yeah, very well.
Small baby is defined if the estimated fetal weight is seen to be less than 10th percentile, then we call it a small baby. But is small baby synonymous with fetal growth restriction? I would definitely say no. And the best fetal parameter to diagnose FGR is, I would go with the Doppler studies. And best method to diagnose FGR, we have to differentiate between early and late onset FGR, and it follows by the Doppler studies.
Okay, so you have opened a Pandora's box now.
Pandora's box opened.
let's push it to others regarding. She said definition of a small baby is synonymous, not synonymous with growth restriction, but the best parameter to diagnose fetal growth restrictions is a Doppler. I want to know whether my other panelists agree with that.
Dr. Wahaj, you have not answered.
Yes.
Can you say the best parameter for growth retardation is Doppler?
We should go for the other parameters also, because we should see the ratios, the head and abdomen ratios, the circumferences, and all these things we should compare.
Okay, Dr. Shrestha, what would you do?
I think only this Doppler study also the main thing to decide the fetal growth restriction, but you have to have a fetal biometry. Fetal biometry, abdominal circumference is a most reproducible and reliable parameter to decide fetal growth restriction. Yeah.
Thank you. I think it's very important to understand that you start suspecting growth restriction when the abdominal circumference is less than 10 centile. So we have this question of small for gestational age. We have AC less than 10 centile, AC less than 5th centile, or less than 3rd centile. The word small comes when the AC is less than 10 centile, or the estimated fetal weight is less than 10 centile. So the question now comes is, all small babies are not growth restricted, and we need to differentiate between small for gestational age and fetal growth restriction. So I'd like the panelists to tell us about the differentiation between the small for gestational age baby and fetal growth restriction. See,
Dr. Ashok?
Yeah.
Dr. Ashok, can you put some light on it? Ashok Khurana?
Yeah, so you see, the Delphi consensus is a group of experts who got together to try and define what is going on. We have 2 groups, the early FGR, which have a different definition, and we have the late fetal growth restriction, which is beyond 32 weeks. In each of these, we must make sure that there are no developmental congenital anomalies, and after that, we then proceed to the definition itself. For the early fetal growth restriction, we have an abdominal circumference or an estimated fetal weight less than the 3rd centile, or an umbilical artery absent end diastolic flow. There is a 3rd criterion where you can have an abdominal circumference or an estimated fetal weight less than the 10th centile and a uterine artery greater than the 95th centile, and or an umbilical artery PI greater than the 95th centile. And that is how we will do this. Of course, remember that the individual measurements of the fetus should be analyzed in each case of a low centile. In the second group, which is my greater than 32 weeks, again, if I have an AC or an EFW less than the 3rd centile, that's a straightforward growth restriction. And then we take any 2 out of the 3 criteria that are mentioned here on this slide that we're looking at. So either the abdominal circumference or the estimated fetal weight less than the 10th centile, or we have an abdominal circumference or estimated fetal weight dropping by 2 quartiles, which is equal to 50 centiles. So like from 70th centile to the 20th centile, or 50th centile to close to the first centile, or a cerebral placental ratio less than the 5th centile, or an umbilical artery PI greater than the 95th centile. So it is a lot of words, but the more you learn to use these, the easier they are to become.
Thank you. Thank you, Ashok. I think this also highlights what Deepika said about use of Doppler for diagnosis of growth restriction, where a combination of abdominal circumference and Doppler depending on the centiles. So any AC less than 3rd centile without any Doppler is automatically growth restriction. But it's between the 3rd and 10th centiles, you need an additional parameter of Doppler to label it as growth restriction. So, but why is it important? Why are we harping so much on SGA and FGR? Sridevi?
Yes, sir, the 2 parameters as we have mentioned earlier, one is the size. Yes. Because the size of the baby, which is either by the abdominal circumference or by the weight, is not actually, it's a surrogate marker. Sometimes, as just now Dr. Ashok Khurana sir has told, the gestational age, the FGR, which is early onset and late onset, that's the same difference, because early onset you see a small baby, but the late onset, the weight is fine. That's why they have put the percentile shift. Yes. So in the small for gestational age, the baby is small, but as we have seen in this chart, the interval growth is fine. Always it is between the percentiles and there is a positive growth and the curves are not actually moving up or down. But the second graph shows that how the curve is coming down from 1 percentile to the other. There's a shift in the growth curve. So this is important not only just when the baby is in the lower percentiles, but also when the baby is in the normal growth, when it comes to term.
Yes. So I think it's important to differentiate this, because the way we are going to follow this pregnancy and the outcomes are going to be different for both. So let's move on to the case study now. She's a 26-year-old, married for 5 years, first pregnancy, she's a G3A2, and then for this pregnancy, she was evaluated. She was evaluated for parental karyotype. APL screen was normal. She's on ecospirin 75 milligram OD, and she is referred for FTS at 12 weeks. And at 12 weeks, the CRL of 57, NT of 1.5. This is what has been given, gestational age assigned as per biometry. Do you want anything more from this report? Ashok, are you happy with the report?
Well, I'm happy with 2 aspects of this report, and that is, of course, that we have a date for this baby and that we have a corrected EDD. There are 2 ways. Some people don't like to correct the EDD if there is a 1-week difference. That's the rules of the Fetal Medicine Foundation. And if you go by the Barcelona group, they say only go by the ultrasound. That's a personal thing. Yes. I still don't know whether this baby is alive or not. I don't have a heart rate here. I must know that. That's the basic thing. The other thing I'd like to know is that, okay, we have a size, but there's a lot more I'd like to know from a first trimester screen report.
Okay. Do you want Dopplers at this stage?
Oh, definitely. I'd like the left and the right uterine artery, and I'd like to take a mean, and then I would be able to assess the prognosis in terms of a growth restriction. After all, she is a precious pregnancy with 2
Okay. Okay. We have got the uterine artery Doppler. Gigi, can you interpret this for us?
Uterine artery Doppler for this patient is very, very important because she has got a bad obstetric history. So we have to do a uterine artery Doppler where we have to look at the PI of the uterine artery. And if it is 2.3, the cutoff being more than 90 percentile or not, depending on that, we should, if she can afford it, she can go in for a pentamarker also, where we can have more pointers to know whether she's going for a placental insufficiency.
Yeah, Dr. Wahaj. Yeah.
It is very good that we should go for the Doppler, and the other parameters are normal.
For all patients?
No,
For all-
not for all patients, but since we had two miscarriage in this case, and now it's a precious pregnancy, so it's better to do it.
Yes. So now we have a slight discussion to make on should you do uterine artery Dopplers for all patients. I'll ask Naren to give his opinion. And
so
then,
when we are doing the 13-week 6-day scan, and we are doing the CRL, and we are doing the early fetal morphology, and we are also doing the NT and NB and the other markers, adding fetal Doppler, uterine artery Doppler to it. And if you want to do a detailed one, the ductus venosus and tricuspid also maybe. But adding a uterine artery Doppler, yes, I would like to perform it this week.
okay. So quick yes or no. Kuldeep, uterine artery Dopplers for all, yes or no?
Yes, sir.
Okay. Sridevi, yes or no?
Yes, sir. We routinely do for all our patients who come for NT.
Okay, right. So the 95th centile for mean uterine artery PI, this is based on the published evidence. For transabdominal scan, this 2.35, and screening by first trimester uterine artery Doppler PI greater than 90th centile. Detection rate for 10% false positive rate is 48% for early preeclampsia, 26% for any preeclampsia. So, so that question is yes, we can screen for preeclampsia in the first trimester. All our panelists agree on that. The markers that are needed. So, apart from uterine artery Doppler, what is the perceived benefit of doing the extended screening? And is there any benefit? Are we able to reduce risk reduction in fetal growth restriction?
Yeah.
By doing screening? Yes.
We have a huge benefit that we look at, which means that when I look at a pregnancy which has an abnormal uterine artery Doppler, and in addition, I'm able to also screen for PLGF, then I'm going to be able to have a huge detection rate for those patients who have a high risk of preeclampsia, which is really the most common cause apart from malnutrition for a fetal growth restriction. And the institution of low dose aspirin at 50 milligrams at night will then be able to reduce my incidence of preeclampsia and therefore preterm delivery and so on hugely. The aspirin trial really told us that we have a 90% success when we're looking at early preeclampsia, 75% for the preterm, which is before 37 weeks, and even for term preeclampsias, we're able to benefit about half of them. Also, the number needed to treat to improve this outcome is only 1 in 120. So in that situation, there are very few numbers needed to treat, in fact, far better than our cervical cancer scoring or our mammogram scoring.
Yes, so that's good. So, so ecosprin is started. It helps reduce preterm SGA by 20% and early SGA by about 40%. So this patient, with whom we are seeing, has a first trimester screen test positive for trisomy 13 and 18. Her trisomy 21 risk is 1 in 600. Her, so can you help us to interpret these results? Whom should I ask? Sridevi, can you interpret this result for us, please?
Sir, the values of PAPA are very low in this patient. So for the trisomy 13 and 18 to be positive by ultrasound, if the baby is structurally normal, I don't advise for a direct invasive procedure.
Okay.
I think more because of her, placental insufficiency for this patient because the PAPA values are very low.
So what about NIPT? Is there a role for NIPT?
If the structurally normal fetus, I don't ask for an NIPT.
So do you think this baby will have growth restriction as it goes along?
Yes, sir. Pardon?
That could be possible. Is it a possibility there's a growth restriction? Okay. Okay, let me just move on. This patient insisted on having a CVS. Of course, as you said, it was not indicated because the CVS turned out to be absolutely normal. But what do we do with this patient? How do we follow them up? When do we call them back? Gigi, when will you call this patient back for a repeat scan?
Next caller for a TIFA scan.
TIFA scan. Okay.
We'll call.
So because it was early, because the parameters were very low, I mean HCG and PAPE and HCG were very low, we reviewed her at 16 weeks. And at 16 weeks, we found the growth parameters, there was a 2 to 3 week lag. So can you comment on these images? Kuldeep, you want to take this?
Yes, sir. Basically, what we're seeing over here is we must have done uterine artery Dopplers at that time also, and we know the PAPE was quite low. So ideal would have been to call them back at 16 weeks, which was done. And we're looking at the pulsatility index both sides, and we need to calculate the mean uterine artery. For 16 weeks, it's still on the higher side.
Yeah.
If we're looking in at the umbilical artery Doppler also, we need to see how much on the percentile it is, but it's definitely the diastolic flow is less. We're looking at a few changes in the placenta as well. So we are not only going to be looking at the fetal anatomy, we need to be looking at the fetal circulation, which is more important because there's a growth lag of almost 2 to 3 weeks.
No, my question is this, can we call this as early onset growth restriction?
Definitely, sir, because we have a dating scan and we're looking at Doppler changes, definitely an early onset growth, fetal growth restrictions are.
So this patient needs close follow-up. Is there a possibility this patient maybe will go for an intrauterine fetal demise?
Sorry, sir?
Is there a risk of adverse event like intrauterine fetal demise?
Definitely, sir, because it's so early looking at such a problem in the Dopplers, the uterine artery and the umbilical. We're definitely going to keep that in perspective and inform the patient about it.
So we did a follow-up. So we did a 20-week, we called her back and it was an intrauterine fetal demise as expected because this baby was good. So the key take-home messages were severe placental dysfunction can present early, look for markers and interpret Dopplers and biochemistry. Do we go and test if screen positive, even if we think it could be false positive test? Because sometimes early IUGR spectrum involves karyotypic abnormalities also, and that's why the karyotype, you interpret uterine Dopplers as part of a multimodality screening in the first trimester. It gives you a better yield of diagnosis. So let's go on to the next case.
Suresh, before you get to the next one, let's ask the people from Nepal and Afghanistan that they are depending only on this thing or they have a good biochemical screening available to them.
Unfortunately, in Afghanistan, we don't have much facilities for biochemical screening.
Dual markers and pentamarkers, no.
Yeah. And even we don't have very good Doppler centers. In Kabul, maybe we have got 1 or 2. Okay. And the rest of the cities, there is no Doppler also. So we mainly depend on biometry.
Yes.
Okay, Dr. Hari, what about Nepal?
We have also in Nepal, actually this biochemistry, all we are sending from here to outside, mostly in India. So we don't have now this facility available in Nepal, this PAPE and this all we have to send double marker, quadruple, all we have to send this all by.
So here is a scenario where the first trimester screen in some places is only being done by ultrasound.
Yeah.
And that is where the difficulty will. Yes.
So let us assume that we did not have Dopplers in the first case. You called her at 16 weeks, and 16 weeks there's a 2 to 3 week lag, and the placenta is looking a little abnormal. That itself will give you an idea that this baby is not doing very well. And then, of course, we call her back for repeat scan. We can't prevent.
That is exactly what I wanted to bring out. People who are in the villages who don't have facility for sending for biochemical markers, PAPE, and don't know how to interpret or this thing, depend on your ultrasound. So do a good ultrasound at least.
Yes. So now let's go on to the next case where the first trimester screening was normal. And again, here the PAPE was 0.1. But at 21 weeks, the growth of AC was 4th centile, estimated fetal weight 5th centile, uterine artery Doppler high resistance, and umbilical artery Doppler was normal. So now what we would like to do, interpreting uterinating Doppler in the second trimester, but since we have, there are two people where we have issues with Doppler, let's consider that there is a baby which is small now. Should we consider this as significant and start her on ecospirin now? She's 21 weeks. Patient is very anxious and wants a treatment. Because once you show some parameters are abnormal, the next thing the patient is going to ask you is, how are you going to treat me for this? So is it okay to start ecospirin now? Who would like to take this? Sridevi, would you like to take this?
Starting ecospirin in the second trimester may not be helpful, sir.
Yeah.
But another thing what I want to just make a small note is if most of these patients, if they are, having this much early, most of this maternal hypertension or some pre-existing maternal conditions do exist in these women.
Yeah.
So if she has already hypertension, the ecospirin doesn't help her.
Okay.
And adding ecospirin in the second trimester also, because already the second wave of trophoblastic invasion is done, it is not much helpful for her.
Okay, so when do you want to review her?
We call her after 4 weeks because the Dopplers are, umbilical artery Doppler is high resistance. So usually 3 to 4 weeks the interval we call.
Yeah. So as Sridevi said, starting aspirin at this point is really not of any benefit because she's already 21 weeks. So now she comes to 28 weeks and here is the growth graph. So Dr. Wahaj, can you help us to interpret this growth graph, please?
Yes, in this graph, what we see, it's well in the percentile, but it's not coming down. And the other one is also touching the 5th percentile.
Yeah.
But here it is going, but here what we see, it is coming below the 5th percentile. And this is that abdominal circumference is much less smaller. And here the femur length is also smaller than expected percentiles.
Yes. So what would be your diagnosis?
It will be asymmetrical restriction or IUGR.
Okay. So now let's since you have brought up the term as asymmetrical IUGR, what kind of terminology would like to use for this? Kuldeep, what would you call this?
So the earlier on we used to be saying as asymmetrical and symmetrical, but no longer now we're just looking in for because it does not tell us about the prognosis as such. So what we are, and this growth chart which you brought up here, sir, is extremely important. One should learn that not to have a cross section, but to have a fetal growth velocity. And we're looking at the abdominal circumference and the femur length, which usually start going beforehand. And we are looking at DHC also, which is almost close to the 5th percentile.
Okay.
So the thing is, we need to be following it up with the Dopplers properly so that we are well aware of where are we standing, because this is at 28 weeks. Sir.
Okay, we have done the Dopplers.
So the label then is early onset FGR.
Yeah. Yes, thank you. Ashok, this is a classical presentation of an early onset growth restriction. But the next question is, once you have a baby with early onset growth restriction, it actually triggers off a different kind of a surveillance protocol. Because she's 28 weeks now, there is an IUGR, which we all agree that there's an IUGR. The umbilical artery Doppler shows 5 PI. Gigi, can you tell us about the possibility of any staging can be done for this?
Like she's almost like in the borderline between 28 and 38 weeks.
Okay.
She's closing up to a late UGR, or she's just on the borderline. The only thing is we'll have to follow up the patient very carefully, ask her to come for frequent visits, like she has to come to us at least how far she's from our hospital. That again depends. We can ask her to come once in 2 weeks for a regular follow-up and see how her fetus is growing. And she may need an ultrasound, along with Doppler, which is very, very important. And you have to give because this fetuses will need an early delivery. So we have to give her a corticosteroid also, which is very important in this particular patient.
Sridevi, would you like to, the kind of staging we can do for this?
Sir, at the present parameters, we would like to add some more parameters if not done. The one is the Leica and also the uterine artery Dopplers and the middle cerebral artery Doppler.
Okay, so here I think I've told you the uterine artery Doppler mean PA is 1.3, MCA Doppler is normal, ductus venosus Doppler is normal. Okay.
Yes, yes, sir.
So I'd like to know, can we give the mother saying this is not very severe at this point? Will you time your repeat scans based on what kind of parameters? Ashok, can you?
Umbilical artery Doppler.
Yeah, we have some excellent guidelines from the Barcelona Fetal Medicine Group, which helps us to stage the growth restriction. And that really tells me exactly when should I call my patient for a follow-up and which would be my trigger for delivery. So in terms of the staging, I need to look at the umbilical artery flow. And if I find that there is flow at the end of diastole, then I'm reasonably comfortable and I would need to follow up every week. If I find that there is absent flow at the end of the umbilical artery flow velocity waveform, then I need to know that I am looking at a relatively more serious situation. And I might be able to stretch her to 34 weeks, but in between, I will need to see her at least twice a week. Now, in the stage 3, I have a reversal of flow in the umbilical artery, but I'm still not worried as long as my ductus venosus shows a decent waveform. We then need to follow them up almost daily, unless, of course, she's 30 weeks. In that case, we need to deliver her. And when I have a reversal of ductus venosus, that is an advanced hypoxic stage, really stage 4. And irrespective of what it is, we give her the option of either losing the pregnancy in utero or delivering her, provided she's a little more than 26 weeks after appropriate counseling.
Yeah. So, thank you. So, what happens is this baby with just an umbilical artery forward flow, with all of the Dopplers being dominant, finds in IHR stage, falls in IHR stage 1. The message here is that when you have an early onset growth restriction, and she's only 28 weeks, where when Ashok said we will do a bi-weekly follow-up and deliver at 34 weeks or 37 weeks, as it may be, is the idea is to gain as much gestation age as possible because we want to reduce the risk of prematurity. And the one parameter which is helping us to follow up this baby is your ductus venosus. You can see that the only condition where you consider delivery irrespective of gestational age is DV reversal. As long as DV has a positive flow, we keep following up and you can do even a daily follow-up till you reach about 30 plus weeks. And once you do that, then you are ready to deliver this patient. So at 30 weeks and 2 days, this patient has this parameter, like absent diastolic flow, middle cerebral artery shows, of course, redistribution, and DV is normal. And what would you do at this stage? Will you deliver or follow up? Gigi, what would you do?
Follow up. You can see, look at the CP ratio also.
Yeah.
And
CP ratio.
And you can add your biophysical profile also.
Yes.
Leica.
To see.
Look at the Leica.
And the Leica.
So you ask me anything, I'll tell you. Leica single deepest pool is 6 centimeters.
That's okay. That's normal.
Yes. And CP ratio.
Lower 5, you will wait.
CP ratio is on the 10th centile.
This is stage 2 placental insufficiency, sir.
Okay, stage 2. So what do you want to do? Do you want to, when do you want to call up for a repeat scan?
We can follow it up. Maybe we can do a Doppler every day because we can look for the reversal of the flow.
Yes.
And because the end diastolic flow, as you say, it's stage 2 only. So we can the more the baby is inside the uterus,
yes,
it's better for us.
So let's go back to
that.
Let's go back to our thing. When it says stage 2, it says bi-weekly follow-up, right?
Yes.
Bi-weekly follow-up. So we'll do that. And the big question now is, because once you're dealing with a growth restricted baby, you need the neonatologist to come in at some point.
Yes.
So is this the time for them to come in?
Yes, we have to have a neonatologist sit with the patient.
Yes. Yeah. So what about role of steroids and Maxel?
It becomes very anxious. So the family as such, and talk to them, tell them about the fetal outcome, and then you go ahead, like monitoring.
Yes.
Also the NSCTG will also help us a little bit.
Yeah.
Add more parameters.
Yeah. So
ultimately we should not give a hypoxic fetus, which is again very, I mean, it's very difficult to face that situation.
So you have said we are going to follow up, all of you have said we are going to follow up on this patient. So we are not going to deliver this patient immediately. But what about steroids? Do you give the steroids now?
Yeah.
Or do you wait for some more time?
No, we give the steroid. We give the steroid because we are in the edge.
Naren, we need your expert advice. Do you give steroids now? And what do you give Maxel now?
Maxelf is again given for neuroprotection now, sir.
Yeah.
So we give steroids and Maxelf for this particular patient.
Okay, Sridevi, would you give steroids Maxelf now?
So we give steroids because when there is absent diastolic flows, that's a time we know that the time may not be much because that's a critical point where you see cardiac decompensation changes. And we don't know how fast the changes are going to happen and the delivery is going to be impending.
But the ductus venosus is still normal, isn't it?
Yes, sir. So, because here the monitoring depends only on the ductus, but once it touches the absent diastolic flows, I think the changes might be a little faster as compared to before.
Okay.
But definitely at 30 weeks, yes, consideration of myself is there. But thinking of considering the delivery point of view, we might think of steroids.
Okay, Dr. Shami, would you give steroids and Maxel now?
I think Sami is not on our panel at the moment.
Oh, okay.
Yeah.
Okay, fine. Right, let's go ahead. So the whole idea is between 28 and 30 weeks, daily increment in survival is approximately 0.7%. After 30 weeks, the neonatal survival rate exceeds 90%. So what we would like to do is to push and try to get at least 30 weeks. And there is significant decrease in major neonatal complications. 35% at 30 weeks to less than 10% at 34. At 30 weeks, less than 10 to 34 weeks. FGR infants delivered prior to 30 weeks have a 3-fold higher rate of developmental abnormalities and up to an 8-fold increased rate of cerebral palsy. And that's why we really do not want to deliver. And regarding the timing of Maxel, because neuroprotection, we'd like to give it if you're planning to deliver, isn't it? So if you give too early, the Maxel is not going to be of much use. You probably need to give it closer to the time when you deliver. So the patient was on routine follow-up, and the key things to assess are, of course, you already mentioned about monitoring of the blood pressure and urine proteins. How frequent you are to assess them? We have already said bi-weekly. So 32 weeks. She has now come to 32 weeks and 3 days. Okay, and this is the picture. Umbilical artery Doppler, absent and diastolic flow. Occasional reversal is coming, and here is the ductus venosus for you. Is there any role for biophysical profile, or do we deliver now? And what are the triggers for delivery? Who wants to take it? I think obstetricians. would like to, Hashim?
So it's basically, if you're looking at occasional reversals, still we are looking in for the stage 3 sort of a thing, where we're looking at occasional reversals of end diastolic flow. We can still see them at 24 to 48 hours, sir. If you're looking at stage 3, the NST can be sometimes a good way when we're looking at just doing it every day. If it's not possible to do a Doppler every 48 hours, 24 to 48 hours.
Yeah.
But I would like to add the fact that we can now look at the middle cerebral artery flow, and I find that the fetus is compensating. I can go day by day and postpone my delivery and take advantage of the 0.7% improvement in outcome.
Okay.
If I can add,
yes.
Like I would ask the mother to monitor the fetal movements.
Okay.
So if there is what we call as a mass, that's my maternal alarm signal. If she thinks the baby is not moving as it used to move, then that's a alarming signal again that the baby is going. And I feel biophysical profile will also help. A good moving baby, an active baby, when you do a biophysical profile, you can take it for a little more to be inside the.
And of course, CTG.
CTG also, variability in the CTG. When there is an acceleration, in 10 minutes, there are 2 very good acceleration, about more than 15 fetal heart rate, then also the baby is quite active.
Yes.
So, and the CCTG access, then I know very good. I look at my short-term variations and I'm far more comfortable. And it's being available now in India.
So coming to the giving the steroid cover, a single repeat course of steroids when birth is expected within 7 days, less than 34 weeks of gestation, and more than 14 days since its initial dose, is because if you're already given it at 28 weeks, as you would do, then with more than 14 days, then you would certainly do the repeat steroid. So LSCS was done, 1.15 kg per baby was delivered. He was in ICU for 2 weeks and now 6 months old on follow-up with the pediatrician and doing well. So,
sir, before we close this case, can I just add on?
Yes.
In the biophysical, my experiences, I treat a lot of high-risk patients in this type of IUGRs like 1.5. Biophysical profile, it's very difficult being a baby like this.
Yes.
Every night also you get nightmares whether this baby is going to see the next morning. But some of the things like the CP ratio will be in the borderline, it will be 0.9. If I could get another 24 hours, it would be better. Biophysical profile, especially the fetal breathing movement, if it is good, it is one of the good parameter. Again, like we can wait.
Yes. So we'll go for the last case because we'll be running out of time very shortly. Very quickly, we'll finish this case. He's a 38-year-old, married for 3 years, screen negative, amniocentesis was screen positive, amniocentesis was normal. Target scan at 19 weeks, normal growth and Doppler. Perfect. The growth was absolutely perfect at 20 weeks. So she's a low risk, normal growth. And when do you call her back for a scan? Because if you see the history, it's a natural conception and you've already done the amnio, that's normal. And she's a primey. Target scan is absolutely normal. So do you routinely advise growth scan for all? If so, when do you advise? And Sridevi, what would you do? When should this patient come for scan?
We call for a repeat scan at 34 weeks, sir.
34 weeks. Dr. Wahaj, in Afghanistan, what would you do?
So you need to unmute yourself, Dr. Wahaj.
I would like to see her in 20 to 22 weeks again. Okay. And then
but she's already 19 weeks. Why do you want to?
No, sorry, I would like to see on 25th week and then 32 weeks.
32 weeks. So 25, 30, 32 weeks. Okay. In Afghanistan, do people get scans free of cost or they have to pay for it?
They have to pay for that. But the cost is very low. It is only, 200, 300 Afghani. So they can get it free scan also.
Okay, right. So now regarding our own thing, Ashok, when would you repeat for us?
If we were to look at guidelines, we don't really have a guideline for growth scans.
Okay.
What I to base my guideline on is how many of my symphysiofundal height assessments will miss a growth restriction, and therefore I will not be able to give my patient the benefit of an altered surveillance.
Yes.
Now, if I look at my malnutrition, both in terms of food fads as well as calories, I find that I have an incidence of 20% in my population. Therefore, I will need to correct their nutrition early. And for that, I would like to suggest in patients who can afford it to do a scan at 30 weeks of gestation. I also need to stratify which patients at term can be left to deliver vaginally. And therefore, I suggest a scan at 36 weeks for those who can afford it. Of course, this is not part of insurance or what the state can afford, but a 30 and a 36-week scan because of my high incidence of growth restriction so that I can stratify surveillance in the next few weeks.
Okay, Deepika, just give me a number when will you do a growth scan for a patient who is at an absolutely normal second trimester. Hello? Deepika, are you there?
Deepika is unable to mute, but she said 28 weeks is what she thinks is appropriate.
28 weeks. Okay. See, are you able to see that among the panelists, there is a varying opinion of when the repeat scan should be done? And that's important to know. She was advised a growth scan assessment at 28 weeks, which was absolutely normal. Now, the standard protocol is in a low risk individual, you have a list of minor risk factors and major risk factors. If more than 3 minor risk factors are there, then you call them at 28 weeks. If the uterine artery Doppler is abnormal at 20 weeks, you call them at 28 weeks. If there are no minor risk factors and no major risk factors, then you call them in the third trimester. The timing of the third trimester scan is the most important. So, supposing at 28 weeks, we do the growth velocity is absolutely normal. Does she need further scans? Yes, Ashok said he will call her at beyond 30, 34 or 36 weeks to see whether she can have a vaginal delivery or what. So this patient was reviewed at 34 weeks and this was the scan, right? And I need interpretation for this. Okay, so 34 weeks, are you all happy with this, with the baby, the way the baby is growing? The Dopplers?
It is going more towards the 5th percentile, sir. And the thing we need to be cautious about is she is 38 years old as well, sir.
Okay. So now I want to know, the Dopplers are perfectly normal. Okay. Is this baby going in for a growth restriction?
We need to evaluate, sir, the cerebroplacental ratio as well, not just seeing the absolute values of the Doppler reading, sir.
Okay.
Sir, as the growth chart, the percentiles are moving down. She needs a close monitoring. We can't leave her just because the Dopplers are fine.
Okay. So, now comes the real question. What if I had done the scan 2 weeks later? If I had done the 2 weeks later, as opposed to 34 weeks, see what happens. When we want to screen for an SGA neonate by the estimated fetal weight at 35 to 36 weeks gestation, using the 10th percentile as cutoff, it predicts 63% of affected neonates. And this other paper, meta-analysis, also showed us that later you do the scan is better. 36 weeks scan is certainly better than a 28-week scan. If all other parameters are normal in a low-risk patient, the estimated fetal weight less than 10 centile has a 54% sensitivity. AC less than 10 centile has 78% sensitivity. The 10% false positive rate. So whether 34 or 36 weeks, there is always going to be a discussion about it. But at 34 weeks, this patient AC 5th centile, umbilical artery Doppler normal, DV normal. How do we follow this patient? So weekly follow-up, as we did. Now, at 35 weeks, we found there's a further drop in the growth, and it was diagnosed as late fetal growth restriction. Now comes the biggest question. When do you deliver the baby? So this baby has been dropping. The 35 weeks, there has been a drop in the growth, and we have now branded it as late onset fetal growth restriction. What are the triggers for delivery? Dr. Wahaj, what would you do in your country? Would you deliver her now? Because the cost of neonatal care would be quite high, isn't it? Dr. Wahaj?
Well, I couldn't get the question. If you
Okay.
pass it out.
Will you deliver her now? Will you deliver her now or take her ahead more?
Well, if it's 35th week, we should deliver it now.
35 weeks. Okay.
I think
anyone agrees, disagrees?
I think
I disagree, sir.
I disagree too, sir.
So I
yes.
So I think we have to see MCA Doppler also. The PI index of MCA will decrease.
Yes.
And umbilical PI index of umbilical Doppler and Doctor's Benesus will be increased. And you have to see other movement like biophysical profile, breathing movement, fetal heart rate, and other all will be decreased.
Yes.
So that only one marker for 34 weeks to deliver the fetus is MCA Doppler. MCA, if there is a decrease in MCA PI, then it's alarming.
What about ductus venosus, Dr. Hari? Ductus venosus?
Yeah, ductus venosus will be if there is a reverse wave, and
so there has to be some clear-cut guideline on when to deliver 35, or do we take this baby to 36, another week ahead?
Yes. Yes. So
I would do was to first look at what nursery facility I have and whether I can handle a baby that is delivered prematurely. Otherwise, I transfer the baby in case I was thinking of delivery. And the second condition I would look at is the maternal medical condition. Does she have preeclampsia? Does she have anything? Does she have uncontrolled diabetes, etc.?
Yes.
Then I would like to look at the cerebral placental ratio as my decision to start thinking of a trigger. And I'd like to look at a CCTG to decide how terribly badly off I am.
7th centile. Cerebral placental ratio is on the 7th.
Yes. So that's uncomfortable enough for me to say that, look, I may need to deliver just now, but beyond that, I could still stretch it for a few days if my CCTG is comfortable.
Okay.
So the problem would in the late onset FGR always is that from chronic to acute phases, it comes on in a matter of few hours. Okay. Otherwise, in an early onset FGR, it takes like a few days to come on.
Okay. So
that is why we have a sudden IUFT or a sudden death because of that in the early, in the late onset FGR.
So one day later, we found absent diastolic flow in the umbilical artery. MCA, of course, shows significant increase. The cerebral placental ratio came to 0.52. And the ductus venosus was still normal.
Yeah.
So is it good enough for delivery? Good enough for delivery?
We can deliver her.
Yeah.
Okay. So, yeah. So she's only 35 plus, but because the Doppler, the CP ratio had such a big drop, and we are not worried about the ductus venosus at this point, because in late onset growth restriction, the DV is never going to become abnormal. And so early delivery was done. Male 1.6 kg baby, NICU admission for 7 days, and then the baby is doing well. So I think we have sort of run out of time because the time was given up to 8:35, and the time is 8:36 now. And because if there is time, there's one more case, but otherwise we will say.
So we have had probably, no, I think the FIGO webinar has just started on endometriosis. I think we'll have to leave this.
Yes. Thank you very much. And
thank you
all the
cases, sir.
Thank you, Dr.
so
Suresh.
Yes.
Thank you, Dr. Suresh, for wonderfully bringing out these cases and initiating fantastic discussion. And I have no words to thank Ashok Khurana, Dr. Wahaj, Dr. Shri Devi, Dr. Gigi, and Dr. Hari Kishore Shrestha, and of course Kuldeep Singh, our great friend, the friend of the gynecologist, and the two talks which we had. Of course, we missed the talk on epigenetics, and because of COVID, but then even COVID, we wanted to know. So this was first of the CEFOG International webinars. It's a series planned every 2 months, and the next one is going to be in March, which is going to be on genetics. That will be with the with another association, and then we will be having one with the RCOG, one with the FIGO committee, and one with the South Asian Menopause Society. So that is how the CEFOG will be interacting with all the world. And CEFOG, as you just heard, is South Asia Federation of OBGYN societies, and we are 7-8 countries now, and probably will be spreading a little bit more. So thank you very, very much. We had a record number of 180 attendees live and about 220 on YouTube, logged in on YouTube. The whole YouTube link to your colleagues, to your friends to see them later on. Thank you once again. Is Dr. Yusuf, the secretary, there? Dr. Yusuf Latif, the secretary of CEFOG, if you're there, can I ask you to propose a formal vote of thanks? So Yusuf was here, but Yusuf Latif is there. Yes, I can see him. Yeah, there, Dr. Yusuf from the operation theater also, or the clinic.
Yeah.
Dr. Yusuf, formal vote of thanks.
So, can you hear me now?
Yes.
We can hear you. We can hear you.
So it was indeed a pleasure to have all this. And as Dr. Rohana said, okay, we had a galaxy of people coming in. And I'm indeed indebted to Ian Donald School for providing this opportunity, for being with us as a CEFOGian. And we are so happy that Dr. Narendra is part of both of the teams. So as a result, we had a joint excellent lectures for all these. And I'm sure I am, and like me, most of the people on the conference are much, much, much wiser than we were on this. I do remember spending whole of my day in some form of screen in front of me, while in the clinics, we do the ultrasounds, while in theaters, we're doing the laparoscopies, and so on. And I was listening to that Ian Dolan thing, that he was from the Royal Air Force. He thought about the radar and so on, and that got him connected into all this. So all of these things, and the CEFOG is so pleased to be part of the Ian Dolan School, and the whole family is so grateful, especially Dr. Narendra and his whole team, to be making us all wiser. And of course, all of this would not be possible without the support of the technical support from the medical companies who have been part of this, and so on. So be safe, have a lovely evening, and good night from this part of the world. Thank you for everybody for joining us and giving us this time of your precious time and this thing. Okay, thank you, sir.
Thank you, everyone. Good night to all those who are on this part of the equator, and good morning to the Americans who are there on that side of the equator. Be tuned. We will be bringing the next webinar, CEFOG International, on genetics in March. The date will be announced within a couple of days. Thank you for being with us.
Thank you, sir.
Thank you.
Thank you. Thank you, sir. Thank you.
Nice seeing you.
Thank you, sir.
Nice seeing you, Sridevi. Good night,
Thank you,
everybody.
teachers. Thank you.